course, weathered the big storm without any difficulties. And now it's just cold. And of course, since I'm from the north, I'm being blamed for bringing it here. So,
of course.
hey, Michael.
Yeah, growing up in the house with 5 Jewish women, I've been blamed for everything my whole life. Yeah. Even though I'm now 2,000 miles away, they said, the planet is all connected. You're still to blame.
That's of course correct, right?
And there's the Bradshaw man who I got the. I'm hoping the final iteration of your paper earlier today. So it looks very good.
Oh, good. Yeah.
It's like it's ready to go for post New Year. So we can go through it all. I got it.
Michael was a superstar for us. He spoke with our entire staff about MS fellowships and what it meant to him. And it was the staff loved it, by the way, Michael. I haven't.
We already know
that, but it was terrific. Yeah. Really well done.
Yeah.
It was fun talking to everyone, so yeah.
He's a chimeric, he's a chimeric between Harry Potter, Sarah Coretti, Elliot Froman, and of course Michael Bradshaw. But I've never met anybody quite like him. We have these very interesting diatribes at night by email. He's an interesting guy.
I don't know if you can see my picture on the wall or not, but
oh yeah.
It's with Hogwarts Castle superimposed.
That's going to be close to the opening scene of the screenplay I'm writing about 1863 and Charcot at the Salpêtrière and the the women in brackets in the dungeon down below after Pinel has left, and the humanistic treatment of the insane has reverted back to the original tradition of lock them up.
Oh, awesome. Sounds great.
And you think I'm kidding. I started writing this years ago, and Teresa keeps hiding the books from me, but it's almost done. He says, well, who are you sending it to? I said, there's so much crap that's being produced these days. I'm sending it right to Spielberg. Of course I am. and I have an in. So I have a direct in.
Nice.
It's pretty scary, actually.
Oh.
But yeah, my kids have taken that picture you put together with me with the hair, and now it's populated throughout the whole family and former training. And they go, man, his hair has really grown.
Yeah, it's a long tradition of mine to put my mentors into Harry Potter characters. So, in case there's any doubt about the level of nerdiness that I have, it's maximal. It's maximal.
I'm telling you. Well, look, it's 4:45. We've got these are both from the Cleveland Clinic, the Mellon Center for Treatment of MS and Neuroimmunology. So we've got 2 great ones. Is Jenny going first? Jenny, there you are.
So there she is. And I have to drop off the call just a little bit early because I'm going to be with Doris on yet another call this evening that I have to introduce a speaker. So I just wanted to say hi to everybody, and I'm really looking forward to the cases.
Yeah. Jenny, is your colleague there with you or in another room or another place? Oh, there they are. Okay, I can't hear you. You got to turn. I think you have to unmute yourself.
Oh, hello. Hi.
Hi, Jenny. Okay, so you guys are there together. So no matter how bad my behavior is, you guys can police me and yourselves, knowing that you have to finish and she's going to go, and these are 2 extraordinary people training with extraordinary people in an extraordinary center, taking care of very, very formidably complex patients. So I think we're going to go right into it because I think these 2 patient vignettes and your guys' involvement and analysis of it is going to bring before a lot of challenges, and some of which we haven't even had now over the course of this webinar program. So you're introducing some really some new frontiers and some novel ground in terms of molecular immunology. So congratulations on that. We're excited about that. So I'm going to let you introduce yourself and the case you're going to present. Remember, the best of the best get invitations to translate the webinar into case reports for considered publication. We had our first out in November, and the next one coming out in April. We have Michael Bradshaw, who was the fellow last year at Harvard, and his double trouble case with hallucinations and cranial neuropathies and NMDA receptor and demyelinating overlap is the subject of that. It'll be coming out in Neurology N2 in January. So I know a little bit about these 2 cases. I'm excited about both of them, actually. So really excited to hear what you guys have to say. We'll interrupt a little bit, but you'll put up with us a little. I'm sure you will. And we'll be good because we have to get through all. Okay. So I'm going to go off camera but stay unmuted and let you go ahead and begin.
Yes. So I try to stay on time. I'm sure Gabrielle will be kicking my chair when I go over time as well. So excited to get started. This is a very, very difficult case involving a course of several hospital admissions, and hope everyone can learn a little bit something from this case, and I'll try to go in a reasonable pace. So just to introduce myself, my name is Jenny Feng. I'm a first-year fellow at the Mellon Center for MS, and I'm training under Dr. Jeffrey Cohen, and this is a really exciting time for me. I'm really excited to meet you guys and hopefully meet you guys again in the ACTRIMS and to interact.
Hey Jenny, it's already coming up on January. What's the plan for next year? Do you know yet, or are you still a free agent?
I'm doing a 2-year on the Sylvia Laurie training program here. So I'll be here for another year, and after that, I guess we'll see.
Yeah, congratulations. That's wonderful.
All right, thank you. All right, so moving ahead, so I'm going to begin with the case, talk about the case briefly, and then we'll go into the diagnostic, the differential diagnosis, and a little bit more about the actual diagnosis. So beginning with the chief complaint, this is a 21-year-old right-handed African-American male who came to the hospital after he had a 3-minute full-on generalized tonic-clonic seizure, and he is somebody who's never had prior seizure history. And we saw him in the ED. He has a history of a head injury secondary to assault when he was 14 years old, when he was hit in the head with a blunt object. And at that time, head CT was reportedly normal. And he also has a history of child abuse. Family history-wise, interestingly, his mother was diagnosed with MS when she was 34 years old. And she lived in a nursing home since the diagnosis, and then she passed away at 39 years old. And we weren't really sure of the reason that she passed away, and the patient wasn't 100% sure either, but it sounded like her course was pretty bad. He has one brother and one sister who are healthy, as far as we know. He has this young man. He's 21 years old. He's unemployed. He's homeless, and he doesn't have any IV drug use history. And developmentally, reading some of his old child psychiatry notes, it seemed like he had borderline intelligence. He had learning disabilities in writing and reading, and he also repeated first grade once. So he has some academic delay, but no motor delay.
Hey Jenny, did we know if the mom died in a nursing home in Ohio? Were there any records that could be identified or retrieved about, you know, who should be? Obviously, we know about African American MS, but the question being, you know, such a young woman pass away so precociously,
which is unusual in MS. Yes. So she was actually a patient here at Mellon Center. Actually, I have some information on her case and towards the end of my presentation, but we don't have the history from her nursing home. No.
Okay.
I believe this is in Ohio somewhere. Yeah.
Okay.
All right, so moving forward, review system-wise, he has been having headaches for the past year or so before he came to the hospital, and he has been having some low-grade fevers in the past couple months. Otherwise, the review system was negative. And moving on to the exam, so when we first saw him after the seizure, he was rather combative, and we couldn't get a proper exam. But after he came out of the post-ictal state, he was awake, he was alert, oriented, and he had rather like a flat affect. But otherwise, speech was okay. His cranial nerves were intact. He does have left-sided weakness in that he was pretty much 2 out of 5 in the arms and in the legs and in the feet. And the tone is also decreased in the left arm compared to the left leg. He also had increased reflexes in the left side as well. No cerebral ataxia, no sensory loss, but he did seem to have neglect on the left side.
Was he combative? It sounds like you got a lot of features there for a right hemispheric syndrome. And, you know, was he agitated, fighting, or is weak in the arm?
Yeah, this is exam actually the day after. The initial exam, we couldn't really get much, but he just couldn't be as combative with the left side. And on the re-exam later, it was found to be 2 out of 5.
For the novices listening to this, be careful of those right hemispheric syndromes. As much as I talk about it, I've been punched innumerable times, including at this more advanced stage of my career, because I get caught up in the whole discussion. The patient looks interested until I get close, and then I get punched in the head. So be very careful with those right hemispheric left neglect patients. You think they don't see you out there, but they may know you're there.
Yeah. Yes. So initially he came to the ED. So obviously everybody in the ED gets a CT head, and you can already see that in the right frontal parietal region, there's a lot of edema and a lot of hypodensity. And this was initially suspect to have an underlying mass. And on MRI imaging, which I'm showing a few selective cuts here, you can see that there's a large focus of the right parietal mass-like lesion. And it does have some unusual enhancement pattern extending across the splenium region of the corpus callosum and also in the cerebellar peduncles, which I couldn't fit into the slide. And
Jenny, want to just make a brief comment about the extension across the commissural pathway? What are you saying? There's, there are more advanced people on fellows, there are residents on, we've even had some students on. So why is that important, that transmission across the commissural pathway there? What do you think?
Well, I mean, for differential diagnosis wise, if you're thinking about something like tumor, this might be something that you can see with GBM that does cross the borders.
Right, but not exclusively limited either. So, right.
No. Yeah.
Okay.
Yeah, and his is certainly this kind of chronic progressive course that he's had would be concerning for that too. And the homelessness, you wonder about tuberculosis exposure and things as well.
Yeah, everybody who's talking, let us know who you are. We want to hear your comment. Thank you. Very important. Okay, Jenny, I'm sorry. Go ahead.
Yeah, so moving on, after seeing this lesion, so the primary concern, was actually, let me just move on to the next slide. So we're thinking atypical demyelination, like tumefactive MS maybe, because this is a very large lesion that's larger than 2 centimeters, has mass effect, has some ring enhancement, or NMO. Sometimes you can see in the extensive confluent patterns that kind of look like tumefactive MS, or MOG, where sometimes you can have fluffy lesions, but they're not 100% typical for those, and they're also obviously with such extensive white matter involvement, you also think about leukodystrophy as well. And then as we discussed earlier.
Yeah, and one other thing, at Mayo Clinic a number of years, maybe 10 years ago, Sean Pittick had a beautiful paper went with the archives before it was JAMA Neurology, the archives on radiographic features of brain lesions in MO. For a long time, people said you'd have spinal cord and eye, but no brain lesions. We knew that wasn't true. But anyway, some of those have these gigantic scallop, very unusual, bizarre-looking lesions in that paper that were absolutely confirmatory for NMO. So I'm glad you bring that up. But that was a Sean Pittick paper in the archives. It's worth having that paper in your collection because it's a nice. It's not common, but it's a diversity of these, and in fact, that's part of the propensity of what that disease can also produce. So anyway. Go ahead.
Yeah, and I saw somebody mention that to add PML to the case, which I do agree, especially somebody who's homeless, if he had underlying HIV, and PML will obviously be in the differential as well. Yeah, and then regarding neoplasm, lymphoma, multifocal GBM, astrocytoma were all reasonable concerns. And also vasculitis sometimes can present like this. And as well, he's a young guy, so it could be metabolic anelas, and infection given his history of homelessness, fungal, TB, syphilis were all reasonable considerations. And on top of that, sarcoidosis, which can pretty much look like anything. So that was part of our consideration too.
Nice review in this week's issue of JAMA Neurology by Barney Stern and the other experts, by the way, on the state of the neurosarcoidosis. Worth looking at. I sent that around last night to some of the members of our team, but you're right, can be anything.
Yeah.
I would say that this is Michael Bradshaw again. We've had a number of cases of neurosarcoid between Vanderbilt and Brigham and Women's and MGH, and the tumor-like appearance is really pretty rare. We only had 2 or 3 cases that had such a prominent tumor-like appearance like this. Usually it's really the leptomeningeal enhancement, and associated with the leptomeningeal enhancement, there may be some white matter disease or cortical disease, but usually it's that would be an unusual presentation for sure for neurosarcoid. But
I have to tell you, Michael, you're right. But having trained at Hopkins and spent a dedicated month with Barney Stern when he was over at Sinai, we never had less than 100 neurosarcoid patients in his clinic, and I've had my pants pulled down and spanked innumerable times seeing those. So they're very rare, but there's an ascertainment bias, and if you're somebody like Barney, an expert, you may collect a few of these because nobody else knows what they are, and you basically go back in, you do it again, you biopsy, and ultimately you find the non-caseating granulomas, and it is what it is. So it's very rare, but it's on the list.
Yeah, exactly. And moving on to further workup, so EEG showed that he did have seizures from multiple regions, and also we recorded 1 seizure coming actually from the left side as well. So moving on to LP, he had it was rather unimpressive with the regards to his radiographic appearance. So he had 2 white cells, but protein wasn't elevated, IgG index wasn't elevated, and he did not have any oligoclonal bands. And we sent for cytology that was negative for malignant cells, and then fungal cultures and bacterial cultures and viral antibodies were all negative. We sent for NMO at that time that was negative. HIV testing was negative, and his metabolic lab, like B12, TSH, all those were unrevealing. And he had a normal serum amino acid testing, urine organic acid testing, pyruvate. Immunodeficiency panel was normal, and the only thing that was positive was that urine was positive for THC and alcohol.
Can I stop you for just 1 second? When you're dealing with, obviously he didn't have, it was only at 21, but he didn't really have early life seizures or other events. But, slow starting mental retardation, there was abuse, there was a bang in the head. The mother had this, had a history of demyelinating disease. But, sometimes when you're talking about with a kid who's not quite right mentally, things have gone on. Then the question comes up, are you dealing with potentially pediatric disorders that might present in adulthood, sometimes even middle and later adulthood, in different ways, cognition, seizures, whatever it may be, and ranges the gamut from urea cycle, amino and organic acidureas, the leukodystrophies, of course, which you've mentioned, Wilson's disease, a whole bunch of things that are on the list. So the question, becomes something like this very unusual story about the mom. So I guess at some point you wonder, obviously you're going to go to biopsy in this case for sure. But when do we start looking more extensively at some of the pediatric diseases that might be presenting in young adulthood? So I guess we'll get there.
Yes. And then, so while he was in the hospital, there were further imaging that were done. So CT, chest, abdomen, pelvis were scanned to looking for a peripheral source, and that was normal. His MRI, despite his brain looking so drastic, his MRI of the C-spine, the T-spine, and L-spine were negative. MRI just showed a reduced caliber in the right ICA, which may be susceptible to artifacts, and the right A1, which I showed you there, is slightly reduced. So the idea of vasculitis was brought up, but the patient refused angiogram, so we couldn't get that imaging in here. So moving on, obviously, like Dr. Frohman mentioned, we're moving on to the biopsy now at this point because he is so young and we do need to find out the cause for this. So he underwent a right frontal brain biopsy, which in that area where, actually just moving forward to the scans of the right frontal lesion that was biopsied. And that showed a angiocentric chronic inflammation with reactive astrocytosis, increased macrophages in that area, and also demyelination. So he received a course, and so this was a pattern that the pathologist thought were consistent with like a vasculitis, vasculopathy kind of presentation. So he received a course of IV steroids for 5 days. And I can show you, I have some really beautiful pictures from the pathologist which I can show. So this is an H&E stain of that area. And this is also H&E stain showing you the angiocentric inflammation there. You have some occasional blood vessel wall infiltrated by inflammatory cells. So that's why the pathologist thought this was the vasculitic pattern of injury. And this is a scan, basically, this is a Gomori methanamine silver for fungi, which he didn't have any. And this is a stain, CD68 stain for macrophages, and it showed that there's a prominent number of macrophages on the intervening parenchyma of the tissue, and occasionally around the blood vessels as well.
Having spent so much time on the Hopkins pediatric neurology service for years, when Sakabu Naidu was there, used to lead the rounds, and Hugo Moser, the grandfather of the adrenoleukodystrophies, to go on these rounds, and occasionally these kids would die, of course, and the whole Lorenzo's oil thing, and some of the adults who were living forever adrenal myeloneuropathy. But Sakabu used to always say that when they looked at these biopsies, they would see features like this, and immediately everybody was saying, why weren't we giving these kids steroids? And of course everybody looked at each other and said, yeah, let's give steroids. And we started giving steroids, and the kids had responses. Now many of them eventually did end up dying eventually, and they had other things, seizures and status, whatever the story may be. But these were sort of features that we were looking at when I was back training then. We're talking now 25 or more years ago. Yeah. That became standard at the Hopkins Lorenzo Oil, Hugo Moser, Sakabu Naidu service. We had no idea how this actually happened in this disease, but once they started looking, as and you're showing it, it's gorgeous micrographs once you see the tissue characteristics, you begin to ask yourself, what's first, what's second, but nevertheless, it's there. And it can't be a good thing, as you know.
Yeah. And have a couple more past slides to show. So basically, there's also benign appearing T and B lymphocyte staining. So this is a stain for CD3 T cells, and this is a stain for CD20 B cells. You can show that there's just benign appearing T and B lymphocyte just kind of scattered throughout the lesion. And this is a neurofilament stain, just showing you that there's small pockets of decreased staining that's associated with the angiocentric areas on the previous slides. And then there's a relative preservation of the neurofilament staining in the intervening regions in the white matter. And last one, this is the Luxol-Fast blue stain for myelin, and basically shows that there's decreased staining, highlighting myelin loss in these areas as well. So MRI, so he got a course of steroids, and then he was discharged from the hospital, supposed to follow up, but unfortunately I guess him being homeless, he missed his follow-up appointment, and then he popped up in the ED 6 months later with just decreased function of the left side. And this is his MRI 6 months later. You can see that compared to 6 months earlier, there's more extensive the T2 hyperintensities in the right area with contralateral spreading now to the left side. The corpus callosum is almost entirely involved now, but and at this point, there's a relative sparing in the parietal occipital regions, but the frontal region is very extensively involved. And you can see that there's interval progression of that ring-like enhancement on the right side.
Just for neuroanatomical purposes, you want to point out that caudal midbrain, the cerebral peduncle on the right, patient's right, this looks like you're getting some now extension right down.
Yeah, exactly. The corticospinal tracts, yes.
Above the decussation, so worsening motor involvement on that left side as it comes down. It's very extensive, but here's like one example of where you see the playing out of that pyramidal Wallerian degeneration.
Yeah. Definitely. So he had another LP. Again, not so much white cells. Protein was increased at 105. Leukocolonal bands again negative, and slightly elevated IgG index. His cytology again negative, and the viral, bacterial, fungal again negative. What was interesting, may have been a red herring, was that his syphilis IgG was positive, just slightly at greater than 8.0, and his RPR titer was also mildly increased at 1 to 32. So ID actually wasn't consulted, but at this time we thought this may just being kind of a red herring on the side, but can't really explain the extensive involvement of his cerebral white matter. But regardless, he was treated with 2 weeks of IV ceftriaxone anyway, and we also obtained PET whole body that showed that hypermetabolism in the brain and in the right apical pleuronodular opacity, which he undergone another CT for and had a biopsy of that area, but it just showed non-specific lymphocytic inflammation. Didn't really show any evidence of malignancy in that area. So moving on to MRI again, because I'm actually shortening. He had multiple readmissions, but I'm going to shorten to just the last one, which is 9 months later. This is now almost a year after his initial presentation. That just shows more left-sided involvement. Now you can see the parietal occipital lobe is becoming involved, and there's also interval enhancement.
And during this time, is there, I know that the vasculitis, treating with steroids, doing all this, was there any sort of working diagnosis that was given that might have translated into some kind of at least guess for disease modifying therapy, or was he basically put the fire out, he's being seen periodically, but wasn't on any kind of chronic therapy or any kind of steroid sparing agent or?
No, not yet, because at this whole time the patient's also very resistant because he has some psychiatric comorbidities. He wasn't very cooperative with treatment, so IV steroids was the only thing that we were managed to give it to him.
Where is he living? Social work and case management, where was he living? Was he going back on the street? He didn't have a place to live. So where did we put this young man?
Yeah, he was living with his family, and that was actually another point that, maybe we could have followed him better with social worker, but as far as we know, he was living with his brother and sister and between a couple of friends.
I see.
Yeah.
Yeah.
Yeah, and then moving on to the repeat LP, again, white 1, elevated protein, ACE levels 82, negative cytology. And he had another repeat biopsy of the similar area and basically showed similar things, some inflammation in the androcentric regions, and also with demyelination. So now the question for the group is, what do you want to send for next?
Yeah, can we hold on 1 second? I know Mike Levy's on the phone. Mike, I can't help because first of all, I love you and I know you're there at Hopkins and you do TM and NMO, but you do everything and you're next door to the Kennedy Krieger. So Mike, can you just sort of just chime in what you think you do or don't know or what you know about this case? But this is so monumental. I got to ask you because you're moving in an orb I used to move in. What would be your thinking through this in terms of, and again, there's no fault. I'm just interested in knowing what people in different places are doing. But Mike, how would you look at this? What would you do?
Well, the features that stand out to me most are the really progressive course of the disease that's really spreading far and wide. This is not some relapsing, remitting autoimmune thing. This is something that's kind of growing in a very malignant fashion. I'd be concerned about missing a malignancy or a horrible infection. But I understand the staining is, it's pretty good. I mean, you got 2 biopsies that are both negative.
Yeah.
Or I just get the sense that there's something growing.
A metabolic derangement. Sometimes when you get that loss of autoregulation, or you've lost the battle against press, and or hypertensive encephalopathy, and now you've brought the pressures down, labetalol, but the whole brain is wet and it keeps going. Patient dies. So there are some, I guess, metabolic thresholds people pass where they just keep going as well. This is it's happening. It's pretty fast, but you wonder, it's anything and everything is is up for grabs on this. But thinking about, again, metabolic derangements, progressive disorders that in childhood would have gone much faster, but in a young adult, for whatever the story may be, something's lit this guy, and he's I'm not sure what you would have done that would have stopped the spread, but that's right. This is really cataclysmic movement across the 2 hemispheres. And if you look at that, even that left side, if you look at the previous films you showed, I mean, it's almost as if the entire white matter is being infiltrated. There was another one which you showed on the left.
Quantiferon, and he also had the brain biopsy was looking for looking for granulomatous inflammation, but the blood quant was negative.
And a chest.
There's another film you have. There's another slide. Can you show that slide where you another image? It's a set of images where you can really just see how much of the see, look at the bottom, the pre-GAD one. Look at this on that left side as well. It's just unbelievable.
And then one more question for the TB testing. Was the biopsy specifically sent to evaluate for TB culture and for special stains?
It was.
I understand granuloma, but did they do extra stains to rule that out?
I believe they did, because obviously with brain biopsy, the tissue quantity was of concern. I don't believe they did in the first one, but the second one they did send for that, and that was negative.
I don't mean to ask a stupid question, but at some point during the evaluation, did somebody do EMG and nerve conduction studies to ask the question as to whether there was any evidence of peripheral involvement? If Mylan is here and he's a young guy and we're thinking about some disorder, whatever the story is, it's moving through white matter tracts. Did he have any evidence of a peripheral demyelinating disease, which would raise the specter of the duo? Sometimes you see it in CIDP, but the major ones, of course, are metachromatic leukodystrophy, adrenoleukodystrophy, adrenomyeloneuropathy, Cockayne syndrome, which he doesn't have, and then, of course, Krabbe's. These are the main ones where you could see, both. And most of those are childhood, adolescent diseases that sometimes present, as you know, in adults. Yeah. But was there any involvement that we thought he might have had a concomitant neuropathy?
Yeah, it was actually scheduled as outpatient, but the patient had follow-up issues, so it was never done. But throughout his exam while he was in the hospital, the sensory modalities on the exam was negative, although he did have the hemi neglect. But EMG was considered, but it wasn't done.
Did he? And I don't recall going back, but did he have reflexes throughout?
He did. He was actually hyperreflexic on the left side.
Good point. Okay.
Could I ask about, sorry, this is Adnan Sube.
Yes.
Hi. Could I ask about response to therapy? So if he was given IV steroids, any other, plasma exchange, IVIG, any response?
No, so he got IV steroids. Actually, I didn't show one of the MRIs after the IV steroids. The enhancement pattern actually improved following IV steroids for one of the times he was hospitalized. But then when he returned without being on a chronic steroid, the enhancement pattern got worse.
But I think what Adnan's bringing up also is, okay, you've got a little flavor that you've put your toe in the water. You've got an anti-inflammatory therapy. We've had something. Question is, on to Cytoxan, plasma exchange maybe first, Cytoxan, or this Froman, Greenberg, Josh Bay, everybody, IV methotrexate with leucovorin rescue, which has been perhaps, I think in our experience, maybe it's biased, the most spectacular defervescent intervention that we've used in many years that was taught to us by pediatric neuro-oncology and pediatric neuroimmunology. But yeah, so that I think that's a legit question. By the way, Adnan, do you know Jenny? You train there part of the time, right?
No, I've been out now 3 years. I don't think we met.
You're an old fart already like me. Okay, Jenny, sorry, keep going. Beautiful, thank you.
No, I actually met Adnan's cousin at one of the meetings, and he trains at UH.
Jenny, you know this is a great patient because you can see how much trouble we're all having. So go ahead.
Yes. Moving on. So we sent for long-chain fatty acid next, and that was positive, showing you can see the columns that are highlighted in red. So the C26 was elevated. So just for reference, in normal C26 would have been 0.23 in somebody who does not have who is supposed to be normal. And so elevated C26 indicate adrenoleukodystrophy because the range would have been 1.3 if you're hemizygote and it'd be 0.68 if you're heterozygote. And you can also see that the C24 to C22 ratio is also elevated. Normal would have been 0.84. And C26 to C22 is elevated. Normal would have been 0.01.
For those of you who don't think these absolute numbers sound big, Jenny could tell you later after the fact that the absolute numbers look close, but normal is so tight that the standard deviation, the number of z-scores away, which is the standard deviation, is very far. They're really elevated.
Yeah. So the interpretation for this long-chain fatty acid panel was that the results were consistent with a defect in the paroxysmal fatty acid chain or oxidation. So adrenoleukodystrophy was considered. And so then we sent for genetic testing, the ABCD1 gene, which stands for the ATP binding cassette subfamily D member 1. And that tests for X-linked adrenoleukodystrophy. And this one actually encodes for a ALD protein called ALDP, and that's actually located on the membranes of peroxisomes. And that one basically allows the very long-chain fatty acids to pass through where they're broken down. So if you don't have this gene, the very long-chain fatty acid kind of accumulate in brain and basically in the myelinated areas. So, and then just FYI, during his hospital, because the X-linked ALD is associated with adrenoleukodystrophy. Adrenal dysfunction. So his testing for cortisol was normal, but his ACTH was actually elevated at 316 picograms per milliliter. So moving on to discussion, just a little bit of information, a couple slides on X-linked adrenoleukodystrophy. So it is a genetic disorder affecting central nervous system white matter, but it can also have a peripheral system involvement as well, as Dr. Froman mentioned earlier. It's one of the most common paroxysmal disorders, being 1 in 17,000 newborn. It's actually since 2016, I believe, it has been incorporated in a newborn screening for all the United States, for all U.S. now. Before, when we initially had this patient, we're looking this up, it was only approved part of the screening panel in New York. And basically, yeah, like I said, it's caused by the ABCD1 gene found on the X chromosome. So just to refresh your memory, the X-linked recessive inheritance, they say the mother is a carrier, and then because I mentioned earlier that the patient had a brother who was healthy, so the brother would have been who would be an unaffected son, and then this would have been the patient. And he had a sister who's also reportedly healthy, but she could have been either a carrier or unaffected. That one we'll have to wait to see. Clinical feature-wise, this was a paper actually published by Dr. Sumit Parikh, who's our metabolic experts here, and basically just showing that XALD you can have psychotic feature, you can have upper motor neuron signs, and you can have isolated like spastic paraparesis, which our patient have both of them. And its childhood onset is most common, but you can have, adult onset, and that can also manifest as adrenomyeloneuropathy or Addison's only. And then this is something interesting that I looked up. So apparently, if you have head trauma, it can initiate the onset of adrenoleukodystrophy. So for our patient, he had head injury when he was 14. Maybe that's what triggered this set of cerebral demyelination. And also, he had a history of physical abuse by his stepfather, so that may or may not have been involved even further before he presented to us. And adrenomyeloneuropathy, AMN, it's very similar in that it's a little bit older onset of presentation, so age greater than 18, sometimes even in the 3rd and 4th decades. You have myelopathy and peripheral neuropathy, and at the same time, you can also have adrenal insufficiency and testicular insufficiency. And 20%
nothing as exciting as what you've presented, though. The ones that I've seen and misdiagnosed until I identified them were much more subtle and much more cryptogenic. They were much more difficult because they go on for long periods of time and then may have more cognitive involvement. But their semiology compared to the children is very, very different, much more insidious.
Yeah, and for this patient, he did have, learning disability when he was young. He had to repeat 1st grade, so maybe that something was already manifesting then, and possibly the head trauma can accelerate this demyelination pattern. And one thing on women who are carriers for XALD, so they can develop a AMN-like syndrome later on, and very rarely they can have cerebral involvement. So we don't have a lot of history on his mother, but if she does have cerebral involvement, could have been a very rare case of carrier with all of these symptoms. And we don't have a lot of history, but we do have imaging from his mother, since she was a patient here at Mellon, and we got a patient's family's consent to obtain these images. It showed that the mother had a few non-specific dots here and there, and this is back in 2014, and she had extensive cord. This is, you can see T2 hyperintensity throughout the cord. So it was as if she had, at that time she was being treated for MS, but if you're looking back at the notes, what the concern was that this may have been an atypical presentation or something that was masking as MS.
For 1 second, hey, Mike Levy, are you still on the phone? But Mike, I'll just put my chips down. I would have passed this. I would have said these look like fairly classic skip lesions. With MS, there's a differential, but I would have bought it. What do you think?
Yeah, they certainly look, post-inflammatory.
Yeah. And limited. So yeah, it could be differential, Jenny, for sure. But I would have bought it, and notwithstanding other features and looking at this, I would have said, oh, okay, yeah, maybe I'll have Mike Levy take a look for me. But Ethan Melton and I would be sitting here looking at these films and say, yeah, these look fairly characteristic for post-inflammatory hyperintensities in the cord. So, and that might have been right. This could be a product of her carrier state, but she may have had MS, and the question is, what is the relationship between them? And I don't know. I don't know the answer to that.
Yeah. And then in terms of diagnosis, so you would get the very long chain fatty acid panel where you look for elevated C26, C24 ratios. It is not pathognomonic because it can be falsely elevated if somebody was on like a ketogenic diet or if you have specimen hemolysis. Also, it can be false negative if you have a diet that's rich in erucic acid, basically if you eat a lot of mustard, canola oil, rapeseeds. You would definitely need to confirm the diagnosis with ABCD1 genetic testing, get the MRI, and in babies who are born, this is already included in all the newborn screening. And then unsupported testing, you would check for, adrenal functions, and you can get VEP to assess disease progression in patients who are maybe, asymptomatic or doesn't have any, brain abnormalities. You can get auditory evoked potentials to check for hearing loss, SSEP to check for myelopathy, and then EMG and NCS would be helpful to see and to check for polyneuropathy as well. And then some of the more classic brain images that you can see with X-linked ALD. This is the picture from a childhood onset of cerebral ALD. You can see that you have a anterior predominant pattern, but the posterior areas can be involved as well, and you have ring-like enhancement of lesions in these patients with overt neurologic symptoms. So that's the quote-unquote inflammatory phase of the disease. So you can have contrast enhancement. And lastly, you can have asymmetry, such as in our patient with X-linked ALD. So this has been seen before. And then, yes.
I just wanted to bring up one other thing about the EMG nerve conductions, because I was overly focused and preoccupied with peripheral and central demyelination. But I'd be remiss if I, having trained at Hopkins, and didn't bring up Dave Kornblath and Vinay Chaudhry's beautiful work with the kids over at Kennedy Krieger, showing that, yes, you can have central and peripheral demyelination. But if you really look at the neuropathies, these neuropathies are mixed, like you can see in diabetes and other things. And a lot of these patients not only have demyelinating features, but there's also features of axonal loss as well. So I want to make sure that I didn't send a message that that's a purely demyelinating neuropathy. Most things are not pure anything, but there are both demyelinating and can have axonal features as well.
Yes.
Important. Yeah.
And then, moving on to management. So if you identify early before the symptomatic phase, the patient can undergo allogeneic HSC, basic hematopoietic stem cell transplantation, and that has been shown to improve survival and maybe stabilize some of the cognitive changes. And then, like we mentioned earlier, there are a couple ineffective or unproven therapies that just we don't have enough data for, or maybe the trials are negative. One is Lorenzo's oil, which a lot of people have been on in the past, and the idea behind it was that it was a competitive inhibitor of the endogenous very long-chain fatty acid production, but Lorenzo's oil hasn't really been shown to be effective at preventing the progression.
Did you watch the movie?
I did not watch the movie, no.
Lorenzo's Oil was a Hollywood production. Nick Nolte, the whole thing. It's probably worth watching. The sad thing, Mike, I don't know if you've seen it, Mike Levy, but they kind of made Hugo Moser look like an idiot, which he wasn't. He was nothing like that character portrayed. But it's a good movie to watch, just to see sort of the desperation that these parents went through. It was actually the parents of the child who actually went through and developed this plan, which was, nice try. It wasn't quite right, but they really did draw a lot of attention to the disorder.
Yeah, exactly. I mean, it is a very devastating disease once you have a child who is symptomatic on it, because there's not a lot of things that can stop the progression. So statins have been looked at, dietary restriction have been looked at, antioxidants have been looked at, but none of it have been shown to have, scientific evidence to stop the progression. Right now, a lot of attention has been on the genetic therapy, gene therapy, meaning you take autologous CD34 positive cells that were transfected with this virus that basically contains the ABCD1 gene. It's ongoing, so we'll be able to see some of the results later. And obviously supportive management, like treating if your patient has adrenal cortical insufficiency, obviously treat for that, and PTOT for spasticity management, anti-epileptics, because these patients can have seizures like in our patient, and obviously genetic counseling.
And a great point is if you thought about, for example, just to throw the old MS pod and some of the therapies, if you threw Lemtrada in here, which deletes your immune system, the problem is that you have autologous reconstitution of the immune system with the same genetics that are coming out of your bone marrow. So your first bullet point is an important one, and most things we would do with MS, we want to be as autologous as possible. Here it has to be allogenic, otherwise you would be rebooting this patient to have the same disease. So it's got to be allogenic, more highly morbidity and mortality, which is why the gene therapy here is really, really so exciting, is to get those stem cells and then replace the gene and then let it go from there. So here's a great example of a bit of a disconnect. We talk about doing BMT for MS. Well, why not Lemtrada? You do a reboot, you change the heritage, the genetics are the same, but we know it's epigenetic and other factors, but not for this disease. For this disease, that would be a stupid intervention, because they're going to repopulate with the same genes, with the same defects. So your bullet 3 is really, I think, the most exciting area to see if that's going to work.
Yeah. And that concludes my presentation.
Yeah, fabulous, fabulous.
Elliot, this is Andrew Goodman. I have a comment.
Please.
So Jim Powers, who was listed as the senior author in the paper that Jenny showed in Trauma as a precipitant for ALD.
Thank you, Andy.
He's a neuropathologist who I worked with here in Rochester for years, but he was a longtime collaborator with the Mosers. And he taught me, Jim, that that often there was an identifiable precipitating event or illness that would then lead to sort of explosive onset of pathology. And I'm just a little suspicious that maybe the syphilis was not indeed unrelated, and maybe that infection was a precipitant to the ALD explosion in this case. So I just food for thought.
Let me back up for 1 second. Jenny, did you guys have an original, when you went way back, there was a VDR that was negative, and then he converted, it was negative to positive, or was it positive from the... So, you know, Andy's point is very well taken, because
I didn't catch that.
The beginning, was it positive from the beginning, or if you went to the original workup for he was tapped before this, wasn't he?
Yeah, so this is, syphilis was positive 6 months later, but the initial LP, which did include syphilis testing, and that was negative.
Yeah, so I think Andy's point about, and by the way, his sort of cognitive compromise early in life, it's never a justification, but you know, parents might have thought, what's wrong with this kid? And he had one bang, but who knows what the nature, the severity, or the extent, the duration of his abuse was. But this may be one example of this multifactorial set of factors, the constellation of which put together might have really ignited him. And I think Andy's point is good. By the way, when we find, you know, profound B12 deficiency in an MS patient, we don't say, oh, you have B12, you don't have MS. You know, we do both. But in this particular case, I sort of passed on that. And I think Andy has a very good point. This would be something to really think about. If you look at the ontogeny of this and the timing, this might have been the perfect storm. And that could have been, he had issues, but this could have been the flame that really lit the final pathway here. And I think it's worth looking back into. It's a very good point, Andy. I think and that in and of itself would make this particular presentation that much more interesting for the readership event to say, you know, it's an unusual disease. We all struggle with this. We get our butts kicked. I get my butt kicked all the time. But some other things happen, and you know, you didn't think for a minute. You didn't bite on that, say, oh, this was syphilis, but you knew you were going to treat it. But the question is, after this really was lit. And by the time you started treating this really went south. It was really not a good thing. So his point is well taken. These factors are not benign. Any of us would pay a price for any singular one of these disorders in the context of what's under the substrate in the cells, peroxisomal, you know, handling of long chain fatty acid oxidase and all the things that happen. This could have actually been a very, very important component in the pathoetiology of his really rapid progressive deterioration. So his point is a really good one.
Yeah.
Did not think about it, did not know that. We'll go back and look at this too, but be prepared. You will be hearing from me, Jenny.
Yes, thank you.
I think that's very, very important.
Also,
any other? I'm sorry, go ahead.
Oh, no, sorry. I think it also highlights something that we could have done better is have better follow-up plan for him. Maybe this wouldn't have taken longer to find out. I think that's another important point for patients who may not have great, who may not appear as, you know, they're the most compliant patients. Important, somebody like this may have been more beneficial for themselves for us to kind of see.
Just real quickly, what kind of case management social work unit or team do you have at the Mellon Center? I know case social workers come and go, but, you know, something we've always focused on as being really important. But do you guys have a social worker or case management team? And do you go out and do home visits and go see where these people live and where they are, particularly really high risk patients?
Yeah, so we do have an in-house social worker. Let me ask my colleagues. We do, yeah. I myself haven't had that many cases where we needed to make home visits, but we do have a social worker team who goes out to visit those high-risk patients, per se.
Yeah, I get myself in trouble because, you know, I'm married to, my better 7/8 who's on the line, Teresa, my center of my universe, the reason why I can do all the things I do. But I have to be careful because I see patients like this. I want to bring them home. I feel I know what's going to happen when they leave, and I just, I worry terribly. The other option is to have a case management social work team where you do all that and you're very close with them. But I do feel that way. I sort of always look beyond the end of my nose, and I know this is not going to go well. And then when it doesn't, I ask myself, well, what did I not do? Because I knew it at the front end, and I have all this follow-up ability to go there. But you can't run this giant home unless you talk to people in Boston who have the Boston home, really severely affected people, or you talk to Ethan Meltzer, who's the architect of thinking about other options in other metropolitan cities to capture these really sick patients. So we can follow the disease and follow, other treatment interventions, and how do we save them from a community which is really not very supportive if you're that sick and lost and don't have your primary family anymore. It's tough.
Yeah.
Anyway, I know we need to get on because I see Kathy, who has put on her bit, looking at me. She
Yes,
knows I'm looking.
This was absolutely fabulous case. Thank you so much, Jenny. But I want to make sure we have enough time for our second case, so it is time to move on. But thank you so much.
I'm going to pull it up for Gabrielle here.
Excellent. Thanks.
Thank you, Jenny.
No problem. I'll still be next to her.
For everybody who's on, Mike Levy, Angie Goodman, thank you so much. Michael Bradshaw.
And you can see her notes.
Okay, hi everyone. So my name is Gabrielle Macaron. I'm a second-year neuroimmunology fellow here at the Madden Center, and I actually trained outside of the U.S. for my neurology residency, and I saw this case outside of the U.S. It was in Paris actually, and it was 2 years ago.
Where were you? At Poitiers, or where were you?
Yes, at La Pitié-Salpêtrière. Yes.
Okay, lovely.
This is the case of a 29-year-old woman who was referred to us for a neurology consult for incidental discovery of brain lesions. She was having a fluctuating inflammatory mass in the left triceps. She would notice like a bump in the left triceps that would sometimes be warm, sometimes be painful, and the overlying skin would sometimes be red. So she had an ultrasound for it. It was unclear what the mass was. It looked heterogeneous. She also had a CT of the arm, and also it was unclear what the mass was. So because there was a concern of a soft tissue tumor, she had surgery for this mass in January 2016. And the mass revealed an hematoma, an organized hematoma actually, which according to the vascular surgeon was attributed to a vascular malformation. So she had a CTA of the neck, and the cuts on the brain showed an abnormal hypodensity. So it was completed with an MRI of the brain in February 2016. And she had 2 large supratentorial lesions that were seen. And at this time, she had absolutely no neurological symptoms.
Gabriella, did she have imaging of the chest, abdomen, pelvis to see whether she had more extensive or disseminated malformations or any hemorrhagic, telangiectatic lesions or anything that might have raised the specter thing? Weber or HHT or?
Yeah, she did, and it was, and they actually didn't find vascular malformation, but that was one of their hypotheses.
Good, thank you.
So her past medical history was remarkable for eczema since childhood. She also was diagnosed with autoimmune hemolytic anemia in 2010, and she has been on immunosuppressant medication since. And she also had a history of recurrent infections, specifically recurrent salmonella, colitis, and septicemia. And at the age of 24, she had a skin rash and was diagnosed with molluscum contagiosum, which is due to the pox virus. She had a history of positive ANA and mild lymphopenia and hypogammaglobulinemia, but she didn't carry a diagnosis of any sort of diagnosis with all of these all of this past medical history. Her family history was unremarkable, and she was currently on low-dose oral prednisone and azathioprine since 2015. She previously was treated with rituximab for her autoimmune hemolytic anemia flare-up, and that was in 2013. So on initial neurological examination, there was nothing. She was completely normal. The patient was stable, oriented, alert, non-encephalopathic. Her speech was normal. Her concentration was normal, and all the rest of the neurological examination actually was normal. She didn't have any eczema at this time or molluscum contagiosum at this time, so the rest of the exam was also unremarkable. Up to now it looks boring, but when you see the MRI, you'll understand.
No. I was going to ask you, have you discovered a new disease? But keep going. Yeah.
It's almost actually. So that was her MRI in February 2016. So it showed a very big lesion in the right frontal lobe, right frontopolar lobe, which has a heterogeneous T2 flare signal in the center and is surrounded by edema. It has a little bit of mass effect on the midline, with a little bit of a shift on the midline, and mass effect on the anterior horn of the right lateral ventricle. And there was a second lesion in the right parietal lobe that looked a little bit older because it appeared less inflammatory, less edematous. That's it. So we completed with GRE, which showed punctuated hypointense lesions inside of the mass. Diffusion showed restriction of diffusion only at the periphery of the lesion with increased ADC. T1 sequences with gadoliniums showed a ring enhancement of the lesion, open ring enhancement of the lesion. And because there was a concern, of course, for tumor, we completed it with spectroscopy, which showed a moderate elevation of the choline peak. And just because spectroscopy, I had to read to remember what each peak means. But the choline peak is usually very elevated in, it's a marker of membrane turnover, and it's usually elevated in high-grade tumors, but also in acute demyelination, inflammation, and anything that can kill the brain tissue, basically. But it's usually higher, a more prominent elevation in the choline peak in such in tumors, for example. And there was a slight decrease in the NAA peak, which is usually reduced in any process that destroys the neuron, such as high-grade tumor or radionecrosis, but also cerebral metastasis and abscesses. She had an increase of lactate peak, which was also not very strong, and it's usually a marker of anaerobic metabolism. And usually in normal people, we do not have, there's supposed to not be a lactate peak. And it's usually so elevated in zones of necrosis inside an abscess or inside a high-grade tumor. And she had mild increase in the lipid peak, which usually is a marker of severe tissue damage when there's a liberation of the membrane lipids. So her profile, although, for us, it was more non-specific, and it was mainly, the spectroscopy was mainly done to make sure it wasn't a high-grade tumor. And we felt that the profile was not suggestive of a high-grade, GBM or something like that. So at this point, we had to think of a differential diagnosis without any clinical symptoms. So it was basically an MRI diagnosis. And I was wondering if someone had any ideas.
It's a new disease.
Dr. Froman, you have nothing to say.
Yeah, it's an unusual. That either means I'm having a stroke, or really, yeah, right. Very, very unusual. This is going to be, yeah, I don't know, but there's some kind of acquired immune metabolic, but molecular immunological change shift. There's going to be something genetic here, but keep going. This is going to be very unusual. This is Macaron's disease.
No, I wish.
Come on. Hemolytic anemia, eczema, a triceps malformation. It's just
actually the diagnosis was very difficult to reach, but I thought that it was interesting to discuss this case here for the differential diagnosis rather than the diagnosis itself.
But I'm not the only one on here. You got some really smart people on here. I love to talk, but I know when it's time to be quiet. It's usually when my wife gives me that look and she has that leftward skew deviation, which means be quiet. The right one means you can keep going. So,
Elliot, don't make me come in there.
Yeah, I'm gonna ask Leora Friedman, one of your French compatriots. She trained where you did with Catherine Lubetsky and others, but she's an imaging person across the spectrum and worked with Jerry Walensky, of course, now for a number of years. But Leora, any idea, any help for your colleague?
Yeah, this one is kind of baffling me. I have to say I do appreciate the spectroscopy.
Yes.
Coming from La Salpêtrière, I really noticed a difference in the utilization of spectroscopy between the U.S. and Paris. So I do appreciate that Gabrielle has put the spectroscopy there. I mean, certainly, you know, I mean, as she very well described the different meaning of the different peaks. The problem is, you know, I mean, you know, a little bit some kind of necrosis, tissue damage, you know, liberation of membrane lipids. I mean, this is not very specific. I mean, I would try to, I don't know, I guess, or in the realm of tumor. I'm interested also in kind of the peripheral ADC restriction. This kind of a
Gabriella, can you go back? Yeah, good. And by the way, at the MS Society, I don't know if Doris or Kathy are on. Jenny, this is not Jenny. We love Jenny, but this is not Jenny Fang. This is Gabriella Mecheron. So if you can change that, just so nobody, you know, who comes on late says, so Jenny, you know, this is not Jenny. So go ahead, Leora. I'm sorry.
Well, you know, I think I'm kind of waiting to hear a little bit. I mean, that's it.
No, you don't get any more. This is it.
Yeah, I don't know. Oh,
come on. Gabriella was disappointed. She says, come on, Froman. You have nothing to say? Come on. That's impossible.
Dr. Froman?
No. Yes.
I would comment that, you know, that the DWI and the ADC is nice because it really goes against this being an abscess. That's at least one thing you can be pretty confident about. You know, the peripheral DWI restriction would be just more inflammatory or demyelinating thing than abscess. So that's nice. But some of the, you know, one question I had was all the molluscum contagiosum, all that stuff, was all of these atypical infections before she was ever immunosuppressed by her doctors?
Yes.
That's what I thought. Yeah.
Yes. And as you know, our last month we had a similar odyssey that we all went down that road together in that 54-year-old woman with lupus who had, you know, a new kind of lupus vasculitis. It was called not lupus vasculitis. It was complications of suppression. So we got to be very, very careful. You know, because he's here, I've just got to do it. Michael, boy, I'm really picking on you today. Michael, you do heads and tails. You do cords and brains. You do everything. You see this stuff. What's your take on this? This is very strange.
Yeah, I'm waiting to hear more details too. I've had a few cases where we've had incidental lesions discovered for whatever reason, and this crosses the threshold for me, and I would work this up with a PET scan, and if it looks suspicious at all, I would biopsy it.
Oh, beautiful. Andy, I'm sorry to say this, Andy, you are the senior tonight. You know, Uncle Bob's not here, but Andy has seen probably everything, and almost everything. And what he hasn't seen, he can hypothesize his way into it. Andy, what do you think of the sequence, just in terms of the clinical history and what we're seeing now radiographically thus far, whether related to the antecedent history or not?
I go along with what I've heard. You know, I mean, I think it's asymptomatic because of the location.
Mm-hmm.
Yeah.
But
it's important. Gabriella, you French?
Yeah. What? Okay. I don't have any additional thoughts. I guess I'm suspicious that it's given where we are or what we're doing, that it's going to be inflammatory. But
but and the antecedent story about the anemia, the eczema, this other thing. There's going to be some. I could be wrong, but I'm
So sure. Obviously, this person has something, you know, absolutely awry with her immune system, and so I'm suspicious that this is going to have something to do with her immune system. But beyond that, I wouldn't be able to say at this point.
Peter,
thank you for pointing out that I'm the senior person.
The genius fellows of Ether, Ethan Meltzer and Peter Squigna, two of the smartest guys I know. You're sitting up there. I've waited till now, but anything you've seen, anything quite like this, Peter? Oh, he may be burping the baby. So
in fact, I am. Yeah, I'm going to be honest. I am. Yeah.
Okay.
But I've got nothing innovative to say here.
Ethan, are you still on? Ethan?
Yeah, no, I have no clue. I think tissue is going to be the answer.
Wow. Gabrielle, you have outdone yourself.
Oh,
You're going to get the prize.
I feel bad now.
No. You're getting a whole supply of the Austin baked French macaroons from me this week. I will send them. Go ahead. I'm listening. Keep going.
So this is Elliot. This is Esther. I also don't know exactly what this is, but just one comment. The lesion is asymptomatic in this patient, and there's also no significant shift in the brain, no significant ventriculomegaly. So I think that's notable. And this lesion may have been there for quite a while. It may not be totally new. So that's the only thing that I wanted to mention.
I agree. And Gabriella, this year's Nobel Prize for Medicine or Physiology was given to the Berkeley and the Japanese scientists on immune system breaking responses, right? PD-1, CTLA-4. So are you celebrating something that you don't know about? Has somebody taken the break off this thing? Go ahead. Keep going.
But you're getting very close, Dr. Frohman.
I'm reaching. That tells you I'm desperate. I'm going to be quiet. Keep going.
Okay, so I just what Dr. Melamed just said is an excellent point on thinking about the differential diagnosis when we see these huge masses in the brain. And I think the first question we should ask ourselves, especially that we only have the MRI to now at this stage, is this a tumor or is this a pseudotumor lesion? And I think that the main aspect on MRI that can help differentiate is the mass effect, because usually high-grade tumors have the mass effect that is usually proportional to the volume of the tumor, whereas pseudotumor lesions often have no or little mass effect because it's a change in the tissue itself rather than a mass that takes place in the brain. There's also other features on MRI that can help us differentiate between pseudotumor lesion and a tumor, like the increased ADC, which usually has a particular pattern for pseudotumor lesion, like Dr. Bradshaw said, in abscesses and in it's usually a central restriction, and in demyelination, you usually have this significant peripheral diffusion restriction. And the contrast enhancement can also help, although that can be variable in both types. But in tumors, specifically metastasis, it's usually a ring enhancement, and in lymphoma, in the immunocompetent individual can have an homogeneous contrast enhancement. Whereas in pseudotumor lesion, it has a peculiar contrast enhancement. For example, the open ring enhancement that we all know in demyelinating lesion, the target sign in toxoplasmosis, and the ring enhancement with a hypo T2 ring, as you can see in the small picture in the lower right corner, which shows a rim of hypo T2 intensity around the abscess, and it's usually accompanied with a ring enhancement pattern. And the spectroscopy is variable in both, but it's usually mostly helpful to diagnose high-grade tumors where there's a significant increase in the choline peak and significant decrease in the NAA peak. And I think that there's a ratio that usually it should be above a certain ratio.
Gabrielle.
Yes.
Can you hear me?
Yeah.
This is Leora. Yeah, I had a question because I really like this table. I think this is really great to just kind of think about looking outside of our, FLAIR, T2 kind of imaging. Also, a comment that I wanted to make is probably something that I would add to this table is thinking outside of the lesion itself. If we have something that's pseudotumoral, if we have something that's on the inflammatory spectrum, we're going to want to look at the spine. We're going to want to look at the eye. We're going to, the orbits, and think a little bit outside of the lesion itself. I was wondering, this is something that I was thinking about after, Elliot put me on the spot, but what is there outside of this?
Great.
It's coming in the next slide, actually. So we did some additional testing. I'll start with the blood work and the CSF analysis, and then I'll move on to the imaging. So she had mild lymphopenia with an absolute lymphocyte count of 710. Her hemoglobin level was 10.1 with high IgH and high reticulocyte count. She had low IgM, but normal IgA and IgG. Her lymphocyte phenotyping showed a severe deficit in CD4 plus T cells, and particularly Tregs, which are the CD25 FOXP3 cells, and NK, but the patient was on Imuran, so we weren't sure if this was due to the disease itself or azathioprine. Her ANA was this time negative. Also, it was reported to be positive in the past. And anti-double-strand DNA and ENA and the lupus anticoagulant panel were all normal, along with the ACE levels. Complement levels were slightly decreased, and she had a normal CH50. Anti-aquaporin 4 and MOG antibodies were both negative, and she had toxoplasma serology, quantiferon, HIV, hepatitis C, B, and VDRL, which were all negative.
Gabriella, say one thing, and that is you very nicely line number 3 onto the blood work, the phenotyping demonstrating the deficit. I want to go to the middle, very important, because if you look at this from a very simplistic point of view for most of us on the phone who mostly do MS, you know, if you were to see somebody in the midst of an MS exacerbation, maybe you would see a clonal frequency shift. If you had a graph with just 2 bars, one was Th17 and the other one was CD25 of your flavor and variety, CD4, CD8, but FOXP3, you'd see during that time likely an escalation in the bar of the Th17, 23, and other pathways, of course, but a diminishment in the CD25 FOXP3 reg cells. And then during that transition into improvement, you would then see the reciprocal shift where the Th17 comes down, CD25 FOXP3 comes up, and that's sort of what you'd see in an immune system not being challenged in somebody, for example, who's normal. So I think this is a very important observation. I'm not saying this is germane to the fundamental underlying problem, but this is important to point out that there is a significant diminution in these regulatory cells for whatever is going on, whether this is the disease state itself, as you say, or this is a product of suppression, which doesn't, you know, only suppress central immune circuit cells, but effector cells, response to recall, all those things can be affected, particularly with the older suppressants. Maybe with Gilenya, we have that dichotomy of what's being sequestered versus what's left in the tissues. But that's an important observation I didn't want to pass by for the more junior people on the line is like, well, what is this FOXP3 thing? But these FOXy cells are ones, I know you're there with Bob Fox, so you can tell him I said that. But these are the FOXy cells that, you know, come from Cleveland and they go other places, and these are good to have a, you know, a fairly good sized population of these. So the fact that these are diminished goes along with the sort of, you know, that inflammatory immune dysregulation, you know, compromise in trying to keep that response under some degree of control. So it's not the end all be all, and neither is Th17, but it's just a general principle I'm trying to underscore. That's not a good thing. If we've got an active inflammatory process going on and your reg cells don't have the ability to dial that down, there's going to be a price to pay in terms of bystander and local tissue damage. So clonal frequencies of these various cells, it's oversimplified, like we used to say Th1, Th2, but there's some relative truth in this, as we've learned about this year's Nobel Prize, and not even in immunology, but what that really meant in terms of ramifications for treatment of cancer. Melanoma, non-small cell carcinoma of the lung, all these sorts of things. So this is the heyday. We used to think this was decade of the brain 40 years ago. Now this is the decade or the next 20 years of neuroimmunology. And I can't let you go by that without saying something to the junior people on the line. Foxy matters, and you got too little Foxy is not a good thing.
Sure. Okay, so CSF analysis was really, really bland. So 0 white blood cells, 0 red blood cells, normal protein, normal glucose, negative bacterial cultures, negative fungal cultures, viral PCR were all negative. Syphilis was done too and was negative. And OCB, the oligoclonal bands were negative, as well as the tortalot. And she had normal interleukin 6 and interleukin 10. So this is something they do a lot in Paris. I haven't seen it here a lot, but as a marker of lymphoma, I'm not sure. And they were both negative, but the patient was on steroids, and it could mask an abnormal interleukin 6 and interleukin 10 levels. So we completed also with the cervical and thoracic spine MRI, and they were both normal. And then a CT chest, abdomen, and pelvis, which also were normal. VEP and OCT, which were normal. So we decided not to biopsy at this time and to follow up with an MRI closely, because the patient was completely asymptomatic, and the spectroscopy was not in favor of a high-grade tumor. So we decided that the benefits, of a biopsy would outweigh the risks in this particular case. So we followed up with an MRI in June 2016, and the patient remained, completely asymptomatic, and we can see that the lesion spontaneously regressed on its own. The lesion, the frontal lesion, particularly diminished in size, and the parietal lesion is barely seen here with just a scarring. There's no contrast enhancement anymore. There's no mass effect anymore. We can see that there's atrophy of the cortex, the cortex that is next to the lesion. And that is her C-spine MRI that we also controlled in June 2016. It was also normal. So at this point, the differential diagnosis changed a little bit because we are, these lesions are spontaneously regressing. So we thought, so this is the patient's MRI on the top right corner, so that you can always compare. And we thought about tumefactive MS or these tumefactive MS variants, Fallot or Marburg or ADAM, but the lack of symptom was not really in favor. This is how their MRI usually look like. The first two are from a patient with Fallot, and the third one is a patient with Marburg variant. They usually die, and it's usually very severe. And the last one is...
Could you very briefly say something to the junior people about the leftward ones in terms of BALO, what that is?
Sure. So do you want me to talk about it?
Well, just we call it the Balo's concentric sclerosis. That what is that? It's very rare.
Yeah,
there it is.
It's thought to be a variant of MS where there's it appears as an onion ring pattern of the lesion around the lesion, and it's thought to be edema surrounding the myelin layers in this way. But I don't think that it's not treated like MS, or I'm not sure.
Who knows how, right? And so I'm glad you said onion ring, because if this was CIDP, right, chronic inflammatory demyelinating polyneuropathy of some chronicity, and you were to cut those demyelinated nerves in cross-section, what you might see is another example of an onion bulb, which are these recurrent waves of D and remyelination with fibrosis and scarring. And the question is whether this is the central nervous system really equivalent, or at least a pattern that looks similar. And these can be absolutely horrific. I know the names of the people that have died on my watch. A 16-year-old when I first arrived at Southwestern, as she was 16, and seizures and all kinds of things. And this thing tracked down into the brainstem, and it was just the most horrific experience. We still have the blocks in the tissues. And so, right, I think it's probably, if we had enough of them, we'd say it's like NMO. Is it a splitter or a lumbar? I'd say it's a splitter. It's got some common features, demyelination, inflammation, but probably not MS. And then you mentioned Marburg's, which is, not the disease of chickens, but this is this like fulminant, rapidly moving kind of MS, which I think our methotrexate leucovorin rescue has put the brakes on numerous occasions. I know Ben Greenberg at Southwestern and others have used this as well in those cases and have had fairly striking outcomes in some of them if you get them early enough. But yeah, this is, I think, part of that whole spectrum of what is MS, what is NMO, what is BOG, MAG, and then you got the ones you see far less commonly, like Balo's and Marburg's, and NMO is more common than we've ever realized. I think Mike Levy would attest to that, but these are really not common. They occur, and they definitely will burn a scar into your heart and your head because you connected to these families, and it doesn't go well, and you will never forget them. We need to do better, but I just wanted to point this out so we just don't gloss over it. If you see this, you should ask for help.
Excuse me, I just wanted to... Hi, everyone. I'm sorry. This is Lynette from the MS Society. I'm just giving you guys your 15-minute warning. I'm sorry. Please continue.
So the other possibilities were NMO, NMOSD, or MOG disorder, but the lack of symptoms was also atypical in this setting. And we also thought about PML because she was immunosuppressed for a while, but it's impossible that PML spontaneously improves. So it was just a thought. Then we thought about inflammatory non-demyelinating disease like neurosarcoidosis, but like Dr. Bradshaw said, I think for Jenny, so there's usually meningeal enhancement, and intraparenchymal lesion often affect the pons and the cord rather than isolated lesions like that in the parenchyma. And we thought about neurovascid, but because it could mimic tumefactive MS, typically with involvement of the thalamus and the brainstem, but usually CSF is inflammatory. We know that in this particular entity, the lesions can spontaneously regress, but it's usually more fulminant when they occur.
And 90% male, right?
Yes.
Yeah.
And and we also thought about histiocytosis, but also it's very rare to be intraparenchymal without any extraaxial involvement. There are some cases of Langerhans or non-Langerhans histiocytosis, like Erdheim-Chester disease or Rosé-Dorfman disease, that can spontaneously resolve, but this is very rare. And we thought that the other possible causes were very unlikely because there was a lot, there were no symptoms, the evolution, and the bland CSF, like, abscesses and neurosyphilis and CNS vasculitis. So in September 2016, she developed symptoms. She had subacute onset, mild sensory changes in the right leg and the right arm, with mild sensory ataxia. And on physical examination, she had decreased light touch and vibration sense, only in the right upper and lower extremities, with mild pinprick sensation impairment as well. There was nothing else. So we repeated the MRIs, and we can see that there's, again, regression of the frontal and parietal lesions that were on the right, but there's a new huge lesion on the left. This lesion looks a little bit like the one we saw earlier on the scans in February 2016. This lesion also has an open ring enhancement pattern. So at this stage, we thought that it's probably inflammatory cause because the lesions are coming and going on their own, and that there's nothing else that could do this, whether it's NMO, NMOSD, MOG, or I don't know, biphasic ADEM, tumefactive MS, neurosarcoidosis, some cases of lymphoma sometimes can also have this sprouting, pattern. So we decided to treat her with IV methylprednisolone, and she received 1 gram for 7 days, and symptoms completely resolved. And we decided to treat her with rituximab, because also her autoimmune hemolytic anemia was active at this time. So we said that it could work on both.
Love it.
Gabrielle,
yeah.
This is Leora, and I have a question. So this patient, before her past history were kind of recurrent infections, if I remember well, colitis. She had a hypogammaglobulinemia. Was her immune kind of deficiency or immune disorder?
So she was thought to
that preceded this case. Was she diagnosed with anything concrete, or how did you, did you ever question, the rituximab in light of her preceding disorder, and or the diagnosis for that matter?
Yeah, we did actually, but it was a collegiate decision, and at this point there were a lot of people working on this case, including immunologists and allergologists and infectious disease and pediatrician and genetician. So it was a collegiate disease to start her on rituximab because she had very mild hypogammaglobulinemia, so just the IgM levels were a little bit low, and her ALC was acceptable. So we thought that, she needed it anyway for her hemolytic anemia, so we decided that we would do it.
And did she have a formal diagnosis as to what kind of immune deficiency syndrome?
She was thought to have some sort of combined immune deficiency, but she wasn't diagnosed. She didn't carry the diagnosis of anything in particular.
Okay, thank you.
Yeah. It's Gabrielle's disease. Keep going.
So that's the MRI in November 16 after the steroids, before starting the rituximab, and we can see that the new lesion also shrank on its own with a little bit of contrast enhancement inside of the lesion that remains. Then we started her on rituximab, and she was perfectly stable and developed no new symptoms. There was an MRI that was done 3 months after her rituximab, which was also unchanged, and that is her MRI 1 year later, which also remained unchanged. So during all this time, we knew that something was not right, and we had to reach a diagnosis. And so there was a lot of people were involved in this. And in the setting of autoimmune and allergic disease, with her autoimmune hemolytic anemia, her eczema, her positive ANA, her immune deficiency with the salmonella infections, contagiosum, the lymphopenia, the hypogammaglobulinemia, and the fluctuating inflammatory brain lesion, we decided to have a genetic testing for primary immune deficiency syndrome. And I think that next generation sequencing was done on a panel of genes, but because I don't have access to her chart, I can't really remember what it was. But she was diagnosed with a very rare mutation in the LRBA genes, which stands for LPS responsive and beige-like anchor protein, which is known to cause a primary immune deficiency syndrome. So that was her diagnosis. So I'm not going to talk a lot about this because I think probably we'll never see this again, but the LRBA protein plays a major immunoregulatory role in the expression and the function and also the trafficking of cytotoxic T lymphocyte associated protein 4, so CTLA4, like you were just mentioning, which is an immune effector molecule that usually acts as an inhibitory checkpoint for the immune response. It usually resides in the intracellular vesicles of Tregs, and they are released after the T cell receptor is stimulated. And it usually acts to inhibit the ligand-driven CD28 function and will counteract the T cell receptor response. So by binding to the tail, LRBA may protect and regulate the degradation of CTLA4 by blocking its trafficking to the lysosomes for degradation.
If I could just say one thing, and Scott Zampiel may be on the line, he may want to interrupt me, but if you go back to the old days and the current days, when we looked at, for example, MS, and you looked at there are alpha and there's beta, there's gamma interferons. We always usually talk about giving beta interferon. We know that we gave gamma interferon, Hill Panage 83. We made people worse with gamma. But it's also true you need all these gammas. If you have a knockout without gamma, you have an animal that just dies. You have to have adequate ability of an immune system to produce toxicity to fight foreign invaders. I'm only bringing this up because one of the pathways we studied for a long period of time are these LPS, or lipopolysaccharide activation, transmembrane signaling of immune activation. And if you did this on cultured cells, you could see these cells would now be expressing MHC class II antigens. They tend to be more pro-inflammatory. You can see adhesion molecules. So it's very important to recognize this is the reverse about thinking about autoimmune disease. This LPS sequence, toll receptors, NF-kappa B, the ability to go out and fight infections, it costs you a bit in terms of producing cytotoxic stress, free radicals, but that's what it takes to kill the foreign invaders. And we would do this in culture to look at the things that would attenuate. For example, many years ago when Richard Ransohoff was at Cleveland, we did a study looking at the beta interferon blocking the gamma activation, and LPS has a lot to do with the signaling sequence. But if you have a problem with LPS or deficiency in this, you've got the reverse problem. It's not we're activating LPS, you have autoimmune disease, or we're killing foreign invaders effectively. Now you've got a problem with immune deficiency. So as rare as you may think this is, understanding LPS, the interferon receptors, understanding the way we used to activate these experiments in EAE and the culture, this was really the heyday of immunology and trying to segregate out these mechanisms of what was pro-inflammatory, what was immunoregulatory, what was too much. If you knock this out of animals, for example, they die because they have to have these abilities to mount responses against foreign invaders. And mistakes are made in both ways. Anyway, it's very, very important. And you may think it's incredibly rare, but maybe what I'll do is get a paper out that reviews this. I'm sure Scott has written about this, about these pro and anti-signaling pathways across the membrane that are so important in understanding the balance between the risk of autoimmunity and the risk of immunodeficiency, and then how lucky most of us are to have balanced immune systems that don't have either. This is a really core mistake. I've never seen it before, but it does make sense. I'll stop. You can finish.
So no, that's the last slide actually of what usually this disease cause immune dysregulation. So people have enteropathy, autoimmune hemolytic anemia, ITP, diabetes, neutropenia. Sometimes they have autoimmune hepatitis, eczema, uveitis. They can have organomegaly or isolated splenomegaly or lymphadenopathy, and recurrent infections. They usually have hypogammaglobulinemia. It can be either IgG or IgA or IgM or all of them. And there were 2 cases in the literature of pseudotumoral fluctuating lesions. One case was biopsied and it was a granulomatous infiltration. And there was a case series on abatacept, which is a CTLA4, which kind of mimics the role of CTLA4 by blocking the CD28, CD80, 86 liaison, and it was positive in decreasing the frequency of infections and of autoimmune disease in these patients. So that's it.
Now, that was an odyssey. Congratulations. That was really amazing. We have a few minutes. Scott, are you on the line? Are you hiding in there? Scott Zambil? No, I know he hears what I'm saying. He sent me a message. But anybody else for any comments? Andy, as the senior father of the group, and have you ever seen anything like this? I never have.
Yeah, I just unmuted. So I've seen several patients who we thought had MS who actually do have, hypogammaglobulinemia, and I've thought there was some relationship, but I've never figured it out to this detail. I've never seen this. To my knowledge, I've never seen these sort of tumefactive lesions. I've seen more typical looking MS in people with some common immunodeficiency syndromes, but not this.
Our big challenge, but these were both spectacular presentations. Gabriella, I'm going to be contacting you. You can't get away. This is, we want to have general MS, treatment dilemmas, all that, but this is something. This is. I don't know if this is Macron syndrome or whatever, but this is something that more people need to read in that section. We have to talk about the prospect of having this here. We do. This is great.
Thank
That's
you.
great. That's the risky
Gabriella, I
part.
just wanted to. Gabriella, this is Esther Malamed. I wanted to say this was really a great presentation and really highlights the importance of really focusing on the patient and really getting a great history of other conditions that they may have had, and to really keep that in the differential. And also the use of molecular sequencing, which we do not jump to too often, but in the correct case, that it's really critical. And as sequencing is becoming much less expensive compared to prior years, this will probably become a tool that will reach to more frequently in the years to come, and will uncover diagnoses that we thought were the common MS and DNMO diagnoses that will shed light onto some of these more intricate and interesting diagnoses. So thank you very much for sharing this case.
Thank you.
Yeah, beautiful. And tell Foxy, Bob Fox, tell him, and of course Jeff, tell him how proud. I can't speak for the other people. I'll tell you for me how proud we are of you of having the courage to present this. This is very, very hard. You can tell how hard everybody was thinking and working on this. So it's not a gotcha. This is the real world, and there are other things out there. We have not learned and discovered everything there is to know about mistakes that can occur. Your last point is a good one. Probably not going to see it, but things are crazy. You'll go somewhere else, could be the other side of the world. You'll end up seeing it. You'll know it, or some variation of it. And experience really does matter. So thank you for having the courage to present that one.
Thank you.
Both you and.
Come catch up with the French neurologist of Houston, Texas, when you come at ACTRIMS, okay?
Yeah, sure. I will. I will.
Okay.
Right,
I also trained with Dr. Lubetsky, so and this was her patient actually.
Oh my. Okay, well, I'm glad we know that, because if it does move to the point, and God willing it will move to the point of inviting you to prepare, we would most certainly like to have her involved and co-author and make comment. As, by the way, I have a list of those who have chimed in and added to the discussion this evening, or admitted that they didn't have as much to add. So you guys will also be hearing about this. These tend to be, it's a consortium of people that are working with you on it. So it's not like any case report you've ever seen. And if you've seen the first one that was in November with this gorgeous image of the pathogenesis of the non-caseating granuloma. If you haven't seen it, go look at that paper from this section in N2 in neurology. It's quite extraordinary. So, and we cover the cost of producing these amazing medical illustrations with our artist Jason Uwe, who's in Melbourne, Australia, but about to move to Emory very, very soon. So anyway, I will, it's 6:17. I think I'll take the end point here and close this month's edition of the webinar. And thank you guys. This was really great having you both in the same office. That kept it on time. And whereas I'm notorious for keeping us off time, but I know Leora is like she's like in my left ear saying, "You're done, Elliot." So it's like having two wives, you know. So anyway, thank you so much for everybody participating, and we'll look forward to seeing as many of you as possible next month during the webinar. Scott Gold, I know you're on there. I'm picking on you next time. That's it. And I will talk to you guys next month. Fabulous. Thank you so much. Okay. Good night.